I'm delighted to be here. I'm going to be talking about the epidemic of prediabetes. The paper which came out in the British Medical Journal in July has got most of what I am saying in it, so anybody who's read it can go now. I just want to acknowledge Victor Montori, my co-author, who is the most remarkable analytical mind diabetologist at the Mayo. This came out at the end of July. The following week, I got a phone call from a health technology journalist who wanted to write an article about this program that's on sale from a startup in California, which is a lifestyle program for prediabetes. And he told me about the website, so I went on to it. The first page tells you that 1 in 3 US adults has prediabetes, and most of them don't know about it. And it offered you the possibility of doing the test, which I did. It asked me how old I was, whether I had a family history of diabetes, what my age, what my weight was, 72 kilograms, which I had to multiply into pounds, and my height, 1.78 meters. And then it told me, you are at high risk for prediabetes, according to the CDC, because anyone 65 or older is considered to be at risk for prediabetes, which is an early stage of type 2 diabetes. The lifestyle program they offered cost $130 per month for 4 months, for the first 4 months. And it gave you supported lifestyle advice as to how to lose 7% of your body weight and to increase your physical activity, which I already take the recommended amount of which. Now, the following Saturday, I went to see my team, Arsenal, and carrying in a bottle of water, I got frisked, and I was told I wasn't allowed to carry this water into the stadium. And I said, I need to carry water with me everywhere because I'm at high risk of developing prediabetes. What I'd like to do is to talk about the concept of intermediate hyperglycemia, which I think is a safer word than prediabetes. The concept that it predicts the future development of diabetes and cardiovascular disease, but also knowing about it isn't much good unless you can do something about it. So the idea that you can intervene in people with intermediate hyperglycemia to reduce those future risks. The whole area is a bit complicated because there are 3 different tests used to define intermediate hyperglycemia: 2-hour plasma glucose, fasting glucose, and hemoglobin A1c. And I'm going to talk a little bit about the politics of prediabetes because there's become a sort of hegemony of the American Diabetes Association in the whole discourse and leading onto a discussion about the public health model of healthcare versus an individual medical model. So the concept of intermediate hyperglycemia, it predicts the future risk of diabetes and cardiovascular disease. And for about 20 years, the main definition of intermediate hyperglycemia was that of impaired glucose tolerance, which is a level of plasma glucose after a 75-gram glucose load between 7.8 and 11.1 millimoles per liter. Now, impaired glucose tolerance was extremely well defined. If you had impaired glucose tolerance, around 30 to 50% chance, you had about 30 to 50% chance over the next decade of progressing to diabetes. Very strongly age-related, so a lot of this is people at the age of 60 who will develop diabetes by the age of 70. The other thing about impaired glucose tolerance is that it's a predictor of cardiovascular disease, both cerebrovascular and coronary heart disease. This is a European collaboration whereby the 2-hour glucose concentration is distributed in the population, and you can see the risk of 11 years development of cardiovascular disease. And there's a clear trend that people with impaired glucose tolerance are at higher risk than those with normal glucose tolerance, but at a lower risk than those with frank diabetes. So IGT is a risk factor for both diabetes and cardiovascular disease. Now, when we talk about the risk of diabetes, I think we need to be clear what we're talking about. Diabetes scares the hell out of people, and this is partly a consequence of the diabetes associations. You have pictures on the side of buses of young women having been told they've got diabetes and bursting into tears. Okay, at a young age, diabetes is a frightening disease, but what does it mean in older people? This shows your lifetime risk of going blind according to the age at diagnosis. Okay, so 45, 55, 65, 75, and according to your hemoglobin A1C at the time of diagnosis. Now, bearing in mind that most people who are diagnosed with diabetes are diagnosed in the over 60 age range, if you take a 65-year-old newly diagnosed and with a really not very good diabetic control, their lifetime risk of going blind is 5 in 1,000, 0.5%. 75, that risk is 0.1%. And the other glucose-related complication, which is renal failure, the figures are about the same. So when we talk about predicting diabetes in a 60-year-old, a 70-year-old, we're talking about this lifetime risk of glucose-related complications that is close to zero. And this is highly relevant to the whole discussion about whether statins precipitate diabetes. It doesn't precipitate ketoacidosis, insulin-requiring diabetes. It increases your risk of just getting above the cutoff point of 6.5% hemoglobin A1C. So the idea of glucose-related problems, I do not think are real for people over the age of 60. The glucose-centric approach to diabetes is a fallacy. Now, I would also suggest that if you are able to predict future disease, the advantage of knowing about it is if you can do something about it. So the most important question is, how can you intervene to prevent future diabetes? And if preventing diabetes is simply preventing your sugar level getting from below to above a cutoff point rather than any symptoms, does preventing diabetes also mean preventing diabetes complications? Now, the biggest study of diabetes prevention was funded by the Centers for Disease Control and, by the NIDDK in the United States, and was called the Diabetes Prevention Program, or DPP. The DPP headline results was that 2.8 years of intensive lifestyle intervention produces a 58% reduction in deterioration to diabetes, and if you give metformin instead of intensive lifestyle advice, you get a 32% reduction. More important, I think, is this slide, which is what happens over the subsequent 10 years. The main three groups are shown here. The placebo group are shown in a blue dotted line at the top, and you can see that 10 years subsequent to the intervention, around half of those have developed diabetes. Those who were given intensive lifestyle advice, around 42% have developed diabetes, and metformin comes somewhere in the middle. Now, expressed another way, I would argue, the prevention of diabetes is really just a delay in development of diabetes. The 30% line is crossed at about 3 years for the placebo group, at around 5 years for the metformin group, and at around 6.5 years for the lifestyle group. So the headline results of the DPP, the diabetes can be prevented by intensive lifestyle advice, which is indeed what Omada Health were offering me, 7% weight reduction and 150 minutes physical activity a week. This is really not a prevention so much as a delay of onset of diabetes. But I think the DPP flags up another issue about prediabetes. Here is a condition which is not a disease, which is considered a possible treatment indication for a pharmacological intervention, in this case metformin. What I haven't shown you here is that the fourth group in the DPP were originally randomized to troglitazone, which was an older brother of rosiglitazone, but that had to be stopped very early on in the study because of a number of people developing severe hepatic failure. So prediabetes is a risk factor for diabetes, but it is also a risk factor for exposure to pharmacotherapy. And the concept of pharmacotherapy has taken off in a big way. There have been 2 very big studies with thiazolidine diones, the DREAM study for rosiglitazone and this study for pioglitazone, which headlines a 72% prevention of diabetes over 2 years with treatment of pioglitazone. They did the follow-up glucose tolerance test while the subjects were still taking pioglitazone, so it's not at all clear whether this is truly prevention or disguise of the developed diabetes by the treatment that they're receiving. Now, the other point to make about pharmacotherapy is there are 450 odd studies registered with the clinicaltrials.net of drug treatment for impaired glucose tolerance or prediabetes. And this is potentially going to be a huge market for the pharmaceutical industry. One important point is that the only studies that have ever been done of prevention of follow-up diabetes in people with prediabetes have been done in subjects with impaired glucose tolerance. The other point to make is that in these studies, in the big study, DPP, even after 15 years, there is no evidence of prevention of coronary heart disease, of stroke, of nephropathy, or of retinopathy. So preventing diabetes, if you like, or delaying it, but that's a chemical diagnosis. Preventing the patient-relevant complications of diabetes, no evidence. There is a small study from China, the Da-King study, that has been followed up for 23 years, that has got some suggestive benefits for prevention of hard endpoints, but there are problems with the analysis because of the way the study groups have been combined. So intermediate hyperglycemia, impaired glucose tolerance, hanging around for 20 odd years as the only classification. The problems with impaired glucose tolerance is that you need a glucose tolerance test to diagnose it, and the 2-hour glucose on a GTT is very variable. So if you take somebody who's got a 2-hour glucose of 9.5 and retest them, the standard deviation of that is about 30%, so they can be anywhere between 7 and 12 the second time round. And similarly, somebody who is normal the first time or diabetic the first time can test as impaired glucose tolerant if you test them again 3 weeks later. And 25 years ago in the British Medical Journal, we wrote this commentary about impaired glucose tolerance, arguing that a lot of the deterioration to diabetes is in fact people who were really diabetic regressing to the mean, and there's an admixture of people with diabetes in this intermediate group. But the other main problem with IGT is you need a glucose tolerance test to diagnose it, and that's not going to be very useful if you want to use it as a population health measure. So around the turn of the century, both the American Diabetes Association and WHO came up with the idea of impaired fasting glucose. A fasting glucose of 6.1 to 6.9, the advantage of this was that you didn't need the glucose tolerance test. With fasting, you could test entire populations. The range of impaired fasting glucose is much narrower than that of impaired glucose tolerance. And the other thing about it is that there's no evidence that impaired fasting glucose is associated with elevated risk of coronary heart disease. So it may be a predictor for diabetes. How good or bad is not that clear because it's not as well defined as IGT, but it's no longer a predictor for coronary heart disease. The other thing about it is the American Diabetes Association discovered there weren't as many people with impaired fasting glucose as there were with impaired glucose tolerance. So what did they do? They dropped the cut point from 6.1% to 5.6%. And the World Health Organization didn't like that idea at all because it trebled the prevalence of impaired fasting glucose. So now a third of the US population has got a condition that can be defined on the basis of a simple blood test. Variability is less of a problem than it is with 2-hour glucose. These are studies where people had 2 glucose tolerance tests 2 weeks apart, and you can see on the left the 2-hour glucose, on the right the fasting glucose. And in fact, the coefficients of variation were around 15% for 2-hour glucose, 5% for fasting glucose. But if you look closely, you can see that using the cut points of 100 to 126, which is the 5.6 to 6.9 that the Americans use in their funny scales, people who are defined as impaired fasting glucose on one occasion have a very high chance of not testing again on another occasion. In the old 6.1 to 6.9 range, it's a little bit more consistent. Hemoglobin A1C, as you know, is a test for measuring glycemic control in people with diabetes, and when it became standardized between different laboratories, all of a sudden it offered a great advantage for the possibility of diagnosis of diabetes. And in 2009, the American Diabetes Association decided to convene an international expert committee, 20 people, half of them from the US, representatives from the European Diabetes Association, the IDF, other national associations. And they all agreed that it would be possible to make a diagnosis of diabetes on the basis of A1C and chose 6.5% as the cut point. They also said that the categorical clinical states prediabetes, IFG and IGT fail to capture the continuum of risk and will be phased out of use as A1C measurements replace glucose measurements. But they did recommend preventative interventions if A1C was over 6 and maybe below if the patient was demonstrably at high risk. Now, what happened next was that the American Diabetes Association Professional Practice Committee met 6 months after this committee published its data and decided to reintroduce the term reintroduce the term prediabetes. And they said prediabetes is either impaired glucose tolerance, which is the 2-hour glucose of 7.8 to 11.1, or impaired fasting glucose according to the ADA, not the WHO criteria, or a hemoglobin A1C of 5.7 to 6.4. Comparing impaired fasting glucose, old and new, I showed you on the left, comparing the rates of raised A1C in this intermediate range. That's 6 to 6.4, that's 5.7 to 6.4. So the lower cut point trebles the prevalence of intermediate hyperglycemia for fasting glucose, and it increases it fourfold or a little bit more with hemoglobin A1C. The ADA criteria have come to dominate the scientific and clinical discourse, despite the fact that impaired glucose tolerance is the only intermediate hyperglycemia that has been tested in intervention studies and the only one that seems to predict cardiovascular risk. But a study that came out in JAMA about this time last year looked at the prevalence and control of diabetes in around 100,000 adults in China. They found the prevalence of prediabetes 50.1%. Prevalence of diabetes 11.6%, which is perhaps a little bit surprising, but China is rapidly developing a diabetes epidemic. 50.1% of prediabetes in Chinese adults, which is 493 million people. If you use impaired glucose tolerance, the prevalence is 8.3%. So you've got around a six-fold greater prevalence of prediabetes using the joint grouped criteria of the ADA than this best summarized, best defined characteristic. When we published the paper in the BMJ in July, I got an email from Richard Kahn, who was this is just to make the point that the growth in the pharmaceutical industry in diabetes treatments is being very, very heavily targeted to China and India. And Barclays Investment Research reckons that 29% of the global growth in diabetes treatment over the next decade will take place in China. Richard Kahn was the Chief Scientific and Medical Officer of the ADA who convened the 2009 International Expert Committee. He said that they were unanimous that there was no evidence for the category, but there was substantial pressure from CDC, the Diabetes Division of the Centers for Diabetes Control, that had funded the diabetes prevention program to invest heavily in diabetes prevention. And they felt that by abandoning the term prediabetes, the American Diabetes Association was threatening the funding that would be available for NIH, NIDDK to fund diabetes prevention. So rather than the American Diabetes Association expert committee members felt that there was no justification for reconvening, so the ADA decided to get its professional practice committee to consider this, and it was they that reintroduced the term and they that defined the cut points. So my last two slides, prediabetes. As I said, impaired glucose tolerance, the top row is the intermediate hyperglycemia that best predicts. There's evidence of delay and maybe prevention by intervention. Ditto with drugs. It predicts arterial disease. The Chinese study suggests there may be some benefit there. If you go down to any of the other criteria for intermediate hyperglycemia, there are more question marks than answers there. So let me finish with just three possible areas for discussion. The idea that the US is dominating international opinions, and the US model is very much what do we do with the patient who comes through the office door. Second question, we are talking about starting people on a lifetime of treatment for a non-condition in the hope of preventing a future condition which is being defined chemically, and numbers needed to treat maybe 5, 10, 20 should one be treating individual healthy people if there is no likelihood of benefit for the individual? And finally, there are studies that show if you ask physicians the likely gains in QALYs or reductions in events by intervening with glucose-lowering drugs, they've got absolutely no idea. And I would question how ethical it is for a physician to start somebody on a lifetime of treatment without themselves knowing the answers to those questions that they should be discussing with the patient. Thank you very much.
Questions from the audience? Could you just say who you are?
George Zembrowski, University of Alberta. I'm looking at your body, and you obviously have a BMI under 25. And a lot of this epidemic is used to obesity. Can you comment on what it means to go from obesity and weight circumference?
Yes, indeed. I think the idea of obesity prevention is the same as diabetes prevention, and I think that the answers to obesity prevention do not lie in pharmacotherapy. They also need much more attention to healthy lifestyles which are encouraged by healthy cities and healthy eating. And I think that the idea that there are 493 million Chinese adults who are developing diabetes, at risk of developing diabetes despite having BMIs on average 25, means that there are lifestyle things in China that are somewhat different from in Alberta and the United States.
Neil Gray from NHS Choices. Being against something is very important, but it's also good to have a brand we could be for. We've been thinking about launching a campaign to get diabetes, pre-diabetes, type 2 diabetes and obesity reclassified as walking deficiency syndrome. So, if it's something we went for, so I'd like to sign up everyone here, as well as joining all trials. I'd like to sign up to the campaign to focus on walking deficiency syndrome. We need something positive to go for.
Can I just suggest it's not just walking deficiency syndrome, it's standing deficiency syndrome. I think there is something really important about the concept of non-exercise activity. The fact that we have got so many devices that stop us doing absolutely anything. And if you look at the work of James Levine at the Mayo Clinic, who looks at obese and lean people and shows that the main differences are the amount of non-exercise activity they do, rambling around the house to pick up the letters from the doormat, standing at your desk using your computer, using your balancing muscles. It seems to be that deficient, and not getting up from the sofa to change the television channel. It's this deficiency as well as the walking that Muir talks about.
Okay, I'm just going to take one more question, but before I do that, the people who've got spaces, could you squeeze up? And there are about 10, 12 spaces if you want to just come down while we take this last question. There's one here just at the back. Rod, and there's one here.
John Rod Jackson, Auckland. I was kind of going to say what you said is that, just like pre-diabetes is not a disease, diabetes is not a disease. It's a risk factor for the disease, as you said. And I just wanted to comment on the modern diabetic is diagnosed by screening. When I was a junior doc, we only measured someone's glucose if they had symptoms of diabetes. And so it was a completely different risk profile back then. Because the modern diabetic is unlike a smoker, has probably got fat, eating olive oil rather than butter, and so their lipids are a lot better, their blood pressure is better. And much of what we know about risk in diabetics is 20 or 30 years out of date.
Completely agree. The idea that the diabetes that develops with statins, for example, might be a reason not to take a statin is ludicrous. I think the idea that diabetes at that sort of cutoff level is a risk factor for future disease is important. I think that Omada Health told me that I was at risk of developing prediabetes, which is a risk factor for diabetes, I'm at risk of developing a risk factor for a risk factor.
Okay, I'm going to have to stop John there. I think you'll be in demand at coffee time, actually.